Let me stop my sharing.
All right.
Excellent.
All right. Then I use a whiteboard for ovulation induction.
Perfect. Perfect. So the floor is yours, sir.
Okay, thank you. So, Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Dr. Haytham Haqiqatan. As you all know, we've been doing this as a personal effort, like to find somebody to combine all of the efforts into one effort and make it something global, not just what I understood from Dr. Haytham in Saudi Arabia. This is something international, and there's international people attending this meeting. I really appreciate it. Thank you, Dr. Haytham, for the great opportunity. As you all know, that the people who attended my sessions before, we have done 2 sessions that were on ovulation induction. We talked about the oral ovulation induction. We talked about IUI, and then we started to talk about IVF protocols. In the IVF protocols, we talked about the ovulation induction for we're using the Antagonist protocol, and we talked about we started to briefly touch on the Antagonist protocol. So what I'm going to do today to finish ovulation induction, because tomorrow, inshallah, we will talk about ovarian hyperstimulation syndrome. We'll briefly touch ovarian hyperstimulation syndrome today as we go, it's not going to be detailed like the way it's going to be tomorrow. I just want to make sure that, can I go ahead and start now, Dr. Haytham, for everybody?
Yes, okay. Yes, please do, please do.
Okay, so as you all remember, we talked about sorry, one second here, just need my annotation, there you go. As you all remember, we need to remember the name of the ovulation induction agents, okay? So, Dr. Mohammed Al-Atabi موجود? Or he did not come today, maybe he did not, okay. You all need to remember the Gnrh antagonist, the Gnrh agonists, okay? Because these are the 2 critical medications to be able to do ovulation induction, or what we call controlled ovarian hyperstimulation for patients undergoing IVF. The 2 antagonists that are available are Citrolex or Citrotide and Orgalutran, which is the one that's not available in Saudi Arabia. Citrotide is the one that is available. Al-Gnrh في 5, you have to know it for the exam. What are the Gnrh agonists available? For Saudi, most commonly we use decapeptyl. Some centers they use Lupron. Okay. There is Cinarel, which is a nasal inhaler. It was very good. However, there was many issues with it in form of cyst formation, so it fell out of favor. في عندنا Zoladex, okay. The last one is Tredistar. So you have to remember these names to be for the exam purposes, especially if we're talking about endometriosis in the future, if we're going to talk about treatment for it, which might include Gnrh agonist. The next thing you need to remember is the types of FSH. تكلمنا احنا في المحاضرة اللي فاتت إنه في recombinant FSH, okay. وفي ال HMG اللي هو urinary products. So what recombinant FSH do we have? Okay, and then a Purigon or Gonal F. Gonal F probably is the one that is most commonly used in Saudi Arabia because Purigon is not readily available for people. Al HMG اللي موجود most commonly used is Menipure, في Merional, في Fostimon. Okay, so please remember what I want you to remember from here is these 2 categories. Now, just to revise the Gnrh antagonist protocol, so I'm going to clear this, okay? So how do we do a Gnrh antagonist protocol, okay? Now, we bring a lady here, okay? Anybody from the audience attended my lecture? If you're in the chat box, please type, yes, I attended your last lecture. Anybody attended ovulation induction part 2? Okay, Ala, this day here, this line represents what day of the cycle? Hana Abdelal, what day of the cycle does it represent? I don't know if they're allowed to
Day
unmute their
21
mics.
Day
yeah.
21 in the protocol.
No, this is the antagonist protocol. Now we are talking about اللي هو الانتاجونست اللي نسميه احنا الشورت.
Day 21 of the previous cycle.
No, this is antagonist, the short protocol, guys. احنا تكلمنا عن
Day 2 of the cycle.
Right, so this one is day 2 or 3 of the cycle. Excellent. So in this day, okay, what we want to make sure is that the patient is ready to start her stimulation. We worked her up. We talked in a previous lecture how to work up a couple for infertility, who are the candidates for IVF, and how do we prepare a patient for an IVF cycle. Let's say she's ready. You tell her to go home and then to come on date when she gets her period to notify us. So we see her day 2 or 3 of the cycle. طب ليش ما نجيبهم day 1? نجيبهم day 2 or 3 to allow the endometrium to shed off. Okay. Sorry, I'm gonna stop for a second. Dr. Haytham, people, they're texting me right now that they're not able to register. They registered and nothing came to their group. I'm going to send them the link again. إذا ما عندك مانع. Just 1 second.
Yeah, I'm already now checking and الناس اللي registering now, and I'm already accepting them. So they're going to receive everything now. So
okay.
just
Okay. I'll carry on.
So if you want to share with them the registration link, so I can accept them as soon as they do.
Okay, خلاص هو موجود, but I think they just registered it's on the way for them. So we bring them on day 2 of the cycle, okay, and we do an ultrasound and we do blood work for them. Okay, what is the goal of the ultrasound? You want to make sure for the ultrasound that her pelvis is in the quiescence stage, or it's quiet. There's no activity going on, so that you are able to stimulate her uterus and ovaries. So we measure endometrial thickness, okay, that day. Excellent. Najd قالت endometrial thickness should be endometrial thickness should be less than 7 millimeter. Okay. The reason we want it to be less than 7 millimeter. First of all, if it is greater than 7 millimeter, we have 2 concerns here. She's either not in the early follicular phase, يعني بتكون جايتك mid cycle and she's not sure. بتعرفي نساء ما يعرفوا يحسبوا دورتهم. Or she might have an intracavitary lesion, polyp, fibroid, whatever it is, that will be detrimental to the success rate of your IVF. Okay. So endometrial thickness should be less than 7 millimeter. We then go and look at the ovaries. For the ovaries, we want to measure 2 things. We want to measure the antral follicle count. Antral follicle count is to help you estimate the dose of FSH that you want to give to this patient. Okay. احنا قلنا the standard starting dose of FSH for patients in IVF كم؟
150.
150. Excellent. Well, maximum dose come?
450.
450.
Very good. So that's the range, and you decide based on the patient age and antral follicle count. The other thing, you want to make sure that she has no cysts in her ovaries. Okay. If she meets these criteria, okay, then she's a good candidate to go ahead and start her IVF cycle. Most people move to antagonist protocol or short protocol right now because it is more patient friendly and there is less OHSS associated with it. IVF cycles are trying to become nowadays more and more patient friendly عشان يتقبلوها. زي ما شفتوا في الأجونست protocol في Ovulation Induction Part 2, a long agonist protocol is cumbersome to the patient. She starts from the previous cycle, she's injecting for many, many days, and there is more hyperstimulation with it. When she starts here, she starts okay, she's starting only FSH, okay? She's only starting the FSH that you write for her. Gonna left, manicure, وقلنا the way that I do it, I'm just giving you my personal experience, okay? FSH اللي عادة نبدأ and I use recombinant plus urinary, okay? I give her a combination of both, HMG and recombinant. The recombinant, it gives you good stimulation, good number of follicles. When you add a little bit of urinary to it, because of the HCG present in the urinary product, you get good quality and good quantity. So you tell the patient you're starting today, and then Selma أنا شفتها موجودة, she saw me start a few patients today. So we let her go for about 5 days. We know that if you bring her back day 5 of injections, okay, or day 2 of the period, لكنه really day 1 of stimulation, okay? عشان لا تتلخبطوا, okay? So day 5 of the period, but now you start counting day 1 of stimulation, which is really day 1 of stimulation. When she goes for 5 days, she will not prematurely ovulate on you. You bring her back day 5, okay? And the goal from day 5 is you want to make sure that you correctly estimated the type of dose she has, or الدوز اللي تحتاجه عشان to respond. في ذاك اليوم حتسوي ultrasound وحتسوي estradiol E2 levels. What are you looking for the ultrasound? Anybody?
2 follicles, 12 millimeter inside.
Follicles.
So she responded by producing 2 follicles at least that have crossed the 12 millimeter barrier. Okay. طبعا احنا لما سوينا ultrasound في day 2 of the period كلهم less than 10 millimeter. You want to make sure on day 5 that she responded by producing 2 follicles that are greater than 12 millimeter, while estradiol has crossed the 500 millimole. معناته صار في granulosa cell activity عندها. All right. So if she meets that, if she is in that category, it means that you have very well estimated the amount of dose she has. Okay. If she did not cross that barrier, بمعنى the follicles are less than 12 millimeter, or the estradiol, طبعا you measure also endometrial thickness, huh? Or the estradiol is less than 500, then she is underdosed and you need to boost the dose a little bit. And you do not start the antagonist at this stage because it's detrimental. Like, let's assume she met this criteria that day, okay? On that day, you add here on top of the 2 stimulations that she's receiving. Excellent يا هبة. You start اللي هو الستروتايد. وقلنا كم الدوز حقه؟ Sorry, citrotide. كم الدوز حق الستروتايد? Anybody? What is the dose of citrotide? 0.25 milligram. The goal of 0.25, the goal of, sorry, of the antagonist, it's 0.25 يا شهد ولا سهد. The goal of the citrotide is to prevent ovulation. You want to go and aspirate those follicles. You don't want her to actually ovulate on you, okay? So from this day until the day she's done, she will be using the FSH plus the antagonist you have chose for her. Usually we would allow her to go for another 3 days, okay? Another 3 days. ونجيبها back day 8 of stimulation, okay? Why do we bring her back day 8? Okay, we bring her back day 8 for both ultrasound and blood work. اللي هو E2 طبعا, okay? Sorry, E2. Ultrasound, some women who are older in age, we do not understand why, okay? Their follicles divide quicker, okay? And they will be ready on day 8. And if the follicle is greater than 22, it's a bust cycle. لأنه هذه الفوليكل ما حتصير كويسة. نسميها dismature follicle. So for the day, you do ultrasound and blood work to make sure that the estradiol is continuing to rise, which means that the granulosa cell is actively dividing and actively producing estradiol, and that the follicles continue to grow. Most healthy women, they need about 10 days. Okay, they need 10 days of اللي هو stimulation. Okay. When can you say that the woman is ready? Okay. احنا قلنا في ناس يكونوا ready day 11, في ناس يكونوا ready day 12. They are ready when they have at least 3 follicles. When they have at least 3 follicles that are 18 millimeter in size. Now this is the international standard. Okay. They accept 18 millimeter. Why? يعني لو عندها مثلا 3 follicles 18 و 6 16, they will still trigger here. In reality, we do not do that in Saudi Arabia or the countries, and we want the greatest number of mature follicle. A mature follicle is between 18 to 22 millimeter. في بلاد برا, في أوروبا بالذات, في إيطاليا, they do not freeze eggs. Okay, but they just want to get the minimum amount of mature eggs to give the woman to go ahead وخلاص. والباقي they discard. أصلا ما حيسووا freezing للembryos. إحنا we freeze embryos. That's why we in reality in Saudi Arabia حتى لو جاتني day 10 and the 3 follicles 18 وعندها 4 5 ranging between 14 to 16, I push her another day or 2 so that those follicles will be mature when I retrieve them. If she meets those criteria, okay, what I do then, what we do, إيش هنعطيها هنا?
HCG.
HCG, excellent, okay.
or Gnrh.
خلينا نكتبها هنا. HCG. ايش انواع ال HCG؟ في واحدة كتبت بريجنيل، غيره ايش في؟ كوريومون، اكسلنت،
كريمان.
غيره هذول يورينري كلهم. في واحد ريكومبيننت، احد يعرف اسمه؟ مصنع يعني.
بروفاسي.
لا، بروفاسي is urinary again.
اوفيتريل.
Ovitrel, excellent. Ovitrel is 250 mics. التانيين you can give anywhere from 5,000 to 10,000 international units. Okay. Now she's day 10. طبعا when you give the HCG, the timing is very, very critical. So انت سويتي ultrasound, the patient is in your office, and she is ready for ovum pickup نسميها. She's ready for the procedure. Okay. You call the lab. هتقول لها عندي patient ready. احنا حنسوي لها الovum pickup اللي هو day 12, which is here almost, okay? This is the day of OPU. Sorry, let me just do this here. This is the day that she will have her OPU done, okay? طيب, في day 11, هنا, what does she take?
Nothing.
Nothing, it's a rest day, excellent. So if you had a day, so once you give her the ovulation trigger, you tell her the next day is a rest day. And then you will come this day for the ovulation trigger. We like to time the HCG, okay, 34 to 36 hours before the ovum pickup. بمعنى لو قالوا لك المعمل احنا we are ready اليوم هي جاهزة اليوم أحد. You will do her ovum pickup on Tuesday at 2 p.m. Okay. معناته متى حاعطيها اليوم ovulation trigger?
Day at 2 a.m.
2 a.m. tonight. Beautiful. So you guys were paying attention. في هذا اليوم اللي هو day 10, once you give her the HCG, the husband has to produce a sample, whether by intercourse, masturbation. We tell him, sorry, اللفظ العامي, we tell him to empty the pipes. عشان when he comes to give a sample on the day of ovum pickup, it is a fresh sample. ما يكون له 10 أيام ممتنع وبعدين يجي يوم ما يعطينا السامبل يوم الأوفم pickup نلاقي السبرم كله dead ولا not valid for use. Okay? So we do the ovum pickup here. It's a transvaginal procedure. It is done under conscious sedation. And what we're looking for, إيش الماتشور follicle؟ هذا سؤال ممكن يجيكم في الامتحان. What is a mature follicle؟ قلنا. What stage is it؟ إيش نسميها؟
M2.
M2. An M2 follicle is the mature follicle. Okay. يكون كم فيها pronuclei؟
2.
So نسميها 2PN. Okay. 2PN يصير M2 follicle. وكيف نعرف إن M2 تكون well rounded ويكون فيها sorry, let me try to draw it here. Yeah, that's one.
هيكون عندها 2 polar body.
2 pronuclei, yeah, or polar bodies. You're right. Okay. فزي كده تكون mature follicle. That day we can do 2 options for the patient. Okay. We can either do at that day اللي هو straight IVF. Okay. Or we can do ICSI. ICSI stands for what? Anybody? Any volunteer?
Intracytoplasmic sperm injection.
Excellent. So the decision to do a straight IVF or to do ICSI depends on what is the cause of infertility. If it is a severe malfactor, we always do ICSI. If it is a repeated failure of IVF, يعني previous failure of fertilization, okay, or إذا كان advanced maternal age. In those patients, we would like to do ICSI for them. إيش يعني IVF وإيش يعني ICSI? Okay, let me show you the difference. So في straight IVF, نحط هذه we put this egg in a petri dish and we surround it by about 10,000 sperm and we allow for natural fertilization to happen. Okay, so we put 10,000 sperm, we put it in the incubator, and we come back the next day to take a look to see how many of the eggs fertilize. There are some studies that showed straight IVF has a slightly higher success rate than ICSI. What's happening in reality now in most IVF centers, we like to do ICSI for everybody to guarantee fertilization. We don't want the patient to pay all this money وتجيكي بعدها تقولي له والله no eggs fertilized, which can happen in 1% of cases. ICSI, we pick this up, okay? We pick the best looking sperm and we by a pipette, we inject it directly into the egg to guarantee fertilization, okay? So this happens on the day of ovum pickup. That day, the patient starts luteal support. Okay? So when ovum pickup, so when والمرزوق أعطى نعطيها luteal support. Luteal support يكون بإيش؟ بالprogesterone. Excellent. And there are multiple studies that showed vaginal progesterone is much better for these patients than oral progesterone. ايش انواع البروجسترون الفاجينا الموجوده في السعوديه؟
سايكلوجست.
سايكلوجست. ايش الدوز حقه؟
400
400
بي
باي
400 بي اي دي. والثاني ايش هو؟
اندومترين 100 بي اي دي
100 PID.
100 بي اي دي. والثالث ايش هو؟
كراينون 8% بي اي دي
Trinon 8% BID. The company said it's OD, like, and we like to use 8 BID. Okay. In reality, it doesn't make a difference what you use. كل الcompanies تقول لك والله أنا أحسن whatever you're comfortable with and your patient is comfortable with, you can use. Okay. Now, you let the patient go home. When do we bring her back? We either bring her back. Sorry, and if this clear, can I erase it?
Yes.
Okay. So, we bring her back. Okay. الحين لما نسوي الأوفن pick up, this is day 0. خلاص تصفر العداد تاني. And you bring her back either 3 days later or 5 days later. day 3 embryo ايش اسمه؟
cleavage stage embryo
cleavage stage embryo. Okay. day 5 ايش اسمه؟
blastocyst
blastocyst. Okay. Bring the patient back for the day 3 embryo gives you about a 40 to 50% pregnancy rate. Day 5 embryo gives you a 50 to 70% pregnancy rate. So في الاختبار انتوا what they might ask you يحطوا لكم صورة embryo. Okay. Sorry, this is gonna take me a little while, but you have to understand this. So كيف شكل ال cleavage stage embryo? Okay. يكون زي كده. ويكون كم خلية فيه؟ How many cells in it? How many blastomeres? 6 to 8 blastomeres. ويكونوا round shaped cells زي كده. Okay. البلاستوسيست stage. Okay, so the cleavage stage is 6 to 8. البلاستوسيست بدأ يتكون فيها البلاستوسيل. Okay. ويتكون فيها inner cell mass. Okay. يتكون فيها inner cell mass. كم cell البلاستوسيست؟
16.
No, not 16. الدي 4 اللي فيه 16 اللي هو ايش اسمه؟ الدي 4 embryo احنا we don't like to redo لانه بالاكسبيرينس في الاي في اف day 4 embryos don't give you good pregnancy rates. ايش اسمه الدي 4؟ Morula. Okay, morulas don't give you a good pregnancy rate. البلاستوسيست is anywhere between 32 to 64 cells وهذا يكون fluid fill cavity هنا. Okay, fluid fill. So the question that comes to your mind then, why don't we transfer everybody day 5 embryo? Why do we still do day 3 embryos? First of all, it depends on your center.
It will not continue till day.
So that's one reason. Excellent, Marwa. لكن في centers they cannot do day 5 embryos. ما عندهم capability. لأنه day 5 يحتاج culture media معين. لكن every center should be able to form blastocysts so that you get a higher pregnancy rate. When do we decide? Do we push a patient from day 3 to day 5 transfer? Okay. We decide to push them if on day 3
good quality embryo.
يكون عندهم حسب السنتر at least 4 to 6 grade 1 embryos. Okay. كيف نسوي الجريدنج للامبريوز؟ الجريدنج للامبريوز بنسوي شيء اسمه نستخدم كلاسيفيكيشن. ايش اسمه احد يعرف؟ Gardner. Okay. Gardner classification. Gardner classification يعتمد على number of cells. قلنا لازم يكونوا 6 to 8. Sorry. يكون ما في أي granulation يعني ما في أي حبوب داخل الإج داخل البلاستوميرز. أوكي. والكلاريتي حقتها وهي mainly number of cells يكون 6 to 8 و no granulation. If she has, فيتقسم إلى أربعة, grade 1, 2, 3, 4, you can go look it up. Grade 1 and 2, we allow them, if إذا كان عندها at least 4 to 6 grade 1 embryos, we allow her to go to day 5. لأنه if she has less, okay, الidea من pushing her to blastocyst, you want the better quality embryo to continue, right? But if on day 3 she has less than 6 oral quality, ما هو grade 1, it could mean one of two things, okay? It could mean that فعلا the quality is not good, but we still transfer on day 3 because of this pregnancy rate, or the culture media you're using is not very good for blastocyst, and the best incubator for the uterus, for the embryo is the uterus, okay? So you go ahead and return them on day 3. What instructions do we tell the patient after the transfer?
pelvic rest, no
Only
intercourse.
thing you need to tell them is pelvic rest and no intercourse. She can carry on with her daily life activities, okay? She can look after her kids, look after her house. She can go even to work, okay? بس احنا psychologically we tell the patients to rest as much as they can. لأنه لو قالت لك والله يا دكتور أنا طلعت الدرج 100 مرة وهذا السبب اللي طاحت فيه الembryos, our society is still not ready for that. برا كنا نسوي لهم transfer, وكانت 2 instructions that we tell them as a joke يعني, we don't let them to ride horses and not to use cocaine. Other than that, they can do whatever they want. In Saudi Arabia, patients do not accept that. You see, after we transfer the embryo, they're crying, they're emotional. وتحاول تقعد على ظهرها قد ما تقدر. When do we do the pregnancy test?
2 weeks after transfer.
2 weeks after the transfer.
2 weeks after.
If you do it before the 2 weeks, let's say 1 week after the transfer, هيطلع لك positive HCG and she's pregnant. Why?
Because of the HCG we
Chemical.
give for induction.
Pregnancy.
You gave already.
Because no, it's because of the ovulation trigger you gave her. You gave her an injection of HCG, and we know that it might take up 4 to 8 days to clear from the system. Okay, so that's why if she does it after a week, you tell her, no, sorry, madam, this might be a false positive from the HCG you took. Please repeat it 2 weeks later. When do we see her for her first ultrasound after a positive HCG?
3 weeks.
3 weeks is her first ultrasound after. This is in a nutshell her the antagonist cycle. Any questions before I move to the microdose flare? Can we carry on? Okay.
Thank you.
Which one do we take?
So what is the microdose? هذا الثالث protocol that you have to understand. Okay. So هذا البروتوكول اسمه microdose flare. Nobody is doing it. Just in case you get asked about it, you have an idea what it is. Okay. The idea behind the microdose flare, it is mainly used for poor responders. بمعنى واحدة عندها previous poor response, يعني عندها reserve low, previous poor response. So إيش يعني poor response? She produced less than 4 eggs in her previous cycle. Okay. Or she has high FSH, FSH is high, or advanced maternal age. قبل ما يطلع الانتاغونست بروتوكول كان ما عندنا غير الجي ان ار اتش اجونست. فذاتس وير هذه كان مجموعه في دنفر they described it and patients did better. They gave higher number of eggs compared to the long agonist protocol. لما طلع الانتاغونست الشورت protocol they did head to head studies and they found that the response is the same. That's why it fell out of favor. طيب how do we do the microdose flare? Okay, microdose flare, we first give them OCP, believe it or not. We give them OCP for about 18 days, whatever you want to use. I usually like to use Marvelon, okay? Although I don't do this very much, okay? We give them OCP Marvelon. أحد يقدر يفكر physiologically why do we give it?
عشان نقلل الفلير.
نقلل FSH.
So the idea is to try to quiet down the ovaries as much as possible. When you give her OCP for about 18 days, what's happening at that time is one of the ways that the birth control pill works is it suppresses your FSH production, okay? When FSH suppression, because you want to take advantage of any rise of FSH that this patient has. So she would take it for about 18 days, okay? 18 days, but then TGB day 18, okay, of the pill. On that day, you do an ultrasound only in the clinic. For ultrasound, you want to make sure that there is no cysts, okay? Well, endometrium has thinned, endometrial thickness, the endometrium has thinned in response to the FSH that you have given her, okay? Sorry, to the birth control. If she meets endometrial thickness less than 7 millimeter, if she meets that criteria, what you tell her at that day is stop your pill, stop the pill, okay? When you stop the pill, ايش حيصير لها بعد كده؟ حينزل لها period, right? She comes to you, day 2 or 3 of the period, زي antagonist protocol. The only difference here, okay, the only difference إنها حتبدأ to inject that day decapeptyl, okay, 0.1 milligram. Do you know why? It's just basic physiology, okay? Why do we do decapeptyl instead of giving antagonist?
FSH.
down regulation للhypothalamus.
No, that's not the reason.
لا عشان ما في
It's the
FSH
quite
إنه-
opposite, okay? فاكرين الفلير effect؟
ايوه الفنل FSH
لما نعطي احنا decapeptyl the first 3 to 4 days, what happens to the FSH يصير له rise، صح؟ يصير rise للاندوجينس FSH وتعطيه معاه exogenous FSH، فيصير عنده 2 FSHs working on the same time trying to recruit follicles. Okay? But that's why poor responders might benefit from this because you have 2 hits of FSH, external and internal. So this day she starts the decapeptyl and she starts the FSH as well. And usually these are poor responders. فكم الدوز اللي حنعطيه؟ 450.
450.
Okay? And we give it, we give these patients at FSH for about 5 days. Okay? فترجع زي البروتوكول الثانية. And you bring her back for ultrasound. Okay? You bring her back for ultrasound day 5. Sorry. You bring her back for ultrasound and you see her response. Sorry if I'm switching between Arabic and English. I'll try to stick as English as much as possible because there's an international audience. I apologize deeply. I'll stick to English, I promise. So on day 5, as we said before, okay, what we're trying to do here on day 5 is to see the number of follicles. So she has to have 2 follicles at least that have crossed the 12 millimeter follicle, 12 millimeter size. If she has less than 2 follicles, it depends on the age of the patient. Let's say you did all of this and you end up with 1 follicle only. Now comes to, the question becomes the age of the patient, okay? Because if you have less than 3 follicles, okay, scenarios that you can do, you can either cancel the cycle, you say you're not really responding, or you can carry on, or if her tubes are patent, to move this, or the other thing, you can switch her to IUI. When they looked at studies, if you have less than 2 follicles with poor response, the best outcome for these patients was when you carry on with the cycle, even if she produces 1 egg, unless she's above 40. If she's above 40, the outcome will be very poor regardless of what you do. Usually the duration of stimulation for these patients, again, is 10 days, and then you carry on with the egg retrieval. Of course, most of these patients will end up with day 3 transfer because of the lack of good number of embryos in them. Okay, this is microdose flare. When you always use Gnrh agonist, and you start it from the start of stimulation, day 2, to try to benefit from the flare effect. So another brilliant group came and said, okay, we did the ovum pickup here, okay? Why don't we do something called dual stimulation? Did anybody hear about dual stimulation for poor responders? So what dual stimulation means, okay, you picked up the eggs here. As we said in the previous lecture, okay, you have a wave of follicles, a cohort of follicles coming. Some of them might have responded during this stimulation. Some of the eggs some of the oocytes that are there might be sleeping and they don't want to respond. So you try to pick them up in a subsequent stimulation within the same cycle. You allow her to rest here, okay? You allow her to rest for 2 to 3 days and bleed after the pickup. And then you start hitting her again with FSH day 3 for another 10 days. and you do another pickup. The studies have shown when you do double stimulation for these patients, you might increase your oocyte yield by 1 or 2 eggs. However, until today, this did not translate to higher live birth rate, but you add to the cost of the patient. That's why it's still under investigation. Okay? Is this clear to everybody?
Can you repeat the dual stimulation, please?
So dual stimulation, okay, you did your stimulation here with the microdose flare or whatever it is, the antagonist protocol, and then you did your ovum pickup here. Okay? You let the patient rest for 2 to 3 days. You let her menstruate. Okay? Sorry, let me draw a straight line here. 2 to 3 days. Okay? And then you bring her back 3 days later. Okay? On that day, you do an ultrasound for her. And you want to see if there is any follicles. If you can see 1 to 2 follicles, that's fair enough. People who attended ovum pickups with me, any follicle less than 16, I don't like to pick it up. I like to leave it alone, okay? Then it's going to be an immature egg and the lab is going to throw it anyway. So those patients, if you bring her back 3 days after the pickup and you see that there might be 2 or 3 follicles, on that day, okay, you start hitting her here with FSH again, 450 for 10 days. And then you do another ovum pickup here. So you accumulated 2 waves of follicles, okay? You took follicles from here and you took follicles from here. So instead of having 2 eggs to deal with, you might have 3 or 4. So by science, by multiple randomized trials, they found that the dual stimulation, you get a higher yield of eggs, higher number of eggs, but this did not translate, not higher pregnancy rate. They usually, because of the quality of the eggs, is not. So Shakira, we do not like to do dual stimulation yet because we don't know how to perfect this technology yet. Okay?
Doctor, sorry, I have a question. The dual stimulation, do we do pick up at day 5 or day 10 to complete the cycle, then hit it again?
So you did her first cycle. She took 10 days of stimulation. After the 10 days of stimulation, you did your pickup. You let her rest for 2 days, and then you hit her with FSH again for another 10 days. You can do it with antagonist. You can do it in the microdose flare protocol. You cannot do this in the long agonist protocol. Okay? The only protocol you cannot do it with the other long agonist. You can do it with antagonist and with microdose flare. These are the protocols for stimulation that you need to know, and this is all I want you to know for stimulation. The micromanagement of cycles is what you learn during your IVF rotation. When do you bump the dose up? How do you decrease this dose? And this comes by experience. There is no guidelines for it, and they should not ask you this in the exam, okay? They might ask you, what are the FSHs? What are the Gnrh agonists? What are the cycles of IVF? What are the different grades of embryos? Okay, when do we freeze? The other thing you need to keep in mind, and this is the talk for tomorrow, inshallah, when you are starting any patient, you have to be aware who's at risk for ovarian hyperstimulation. This is a teaser for tomorrow's lecture. So which patients, when you are starting IVF, you should worry about them flipping into ovarian hyperstimulation?
Patient with
PCO patients.
PCOS patients, because they have a higher number of eggs. غيره.
thin patient,
Very thin patient. ما هو obese patient. غيره.
young patient,
Count more than 20.
High antral follicle count greater than 20. غيره.
High estradiol.
High estradiol.
Anything in obstetrics and gynecology, they ask you about risk factors, previous same thing. IUGR, previous IUGR. Preeclampsia, previous preeclampsia. Ovarian hyperstimulation, previous ovarian hyperstimulation.
If the patient get pregnant?
No, this is later. احنا قلنا الآن you want to predict which patients will flip into OHSS. Very high estradiol on day 10. Okay? If it is greater than 10,000 on the day of trigger. Okay?
Young age and low BMI.
Young age.
Young age. Very good. Okay? Or very high dose of FSH. You wrongly gave her a very high dose of FSH. Okay? Please remember these risk factors because OHSS should be a disease of the past, okay? I'm organizing now a gynae club, inshallah, حيكون not tomorrow, Monday, the following Monday about OHSS by Prof. Hassan Jamal. And we'll see in that gynae club why nobody should be seeing. And tomorrow, inshallah, I'll tell you why we should not see OHSS anymore, okay? I'm not gonna talk about OHSS today because I want to spend a lot of time because I know a lot of you have trouble for OHSS, okay? Now, I need to summarize this again to emphasize how important it is. Other than Hana, Salma, are you here?
Yes.
Name 5 agonists again. لا تغشي من الورقة. سلمى.
أيوة دكتور. عندنا recombinant وعندنا urinary.
No, so agonists هذاك ال FSH, okay?
Okay, sorry.
هذا الأgonist, okay? So
There you go.
agonist اللي هو we suppress the cycle with. So, okay, so people started writing في decapeptyl,
Zoladex,
Zoladex, أخيرا محمد.
لوبرون
Lupron,
سينرجي
and
Cinarel,
Synergy.
okay? وتريل ستار.
Testosterone,
الانتاجونست مين هم؟
Citrotide and orgasm.
ستروتايد وأورجالوتران، okay? ال FSH قلنا في recombinant وفي urinary صح؟ recombinant زي مين؟
Gonal F,
Gonal F,
Urigon.
Urigon, very good.
Pergovirus.
Pergovirus, very good. Pergovirus اللي فيه FSH و LH. We'll talk about this later on. والurinary?
Menopause,
Manipure, Merional.
Postimon.
and Festimon.
Very good. MashaAllah. I'm very happy. Any questions about ovulation induction you want us to repeat? Anything you want us to repeat?
Doctor,
Yes.
in microdose protocol, we give decapeptyl also for 10 days?
Yes, from the day of stimulation, she starts day 2 until you give her the HCG trigger.
Okay, thank you.
Okay, I have a few questions before we end today's lecture. This is a quiz of everything we did, okay? If you remember from people who attended oral ovulation induction, okay? This is a quick revision. Anybody other than Muhammad Al-Atabi or other than Hana Abdelal, name 2 medications.
Clomiphene, Ultrasound.
Clomiphene citrate وletrozole. مين اللي قال الكلوميفين والletrozole؟ سوري ما لحقت الاسم.
محمد الملحم.
Okay, يا محمد. Clomiphene, what medication is it? What class of medication?
SMERS. Selective estrogen.
Yeah, SERM. Okay.
SERM, sorry.
Selective estrogen receptor modulator. Okay. You remember? Can you explain to me how it works? أول شيء قبل how it works. إيش الدوز حقه minimum maximum?
50 to 150.
150. There is no point of giving one more than 150. How many cycles do you allow the patient to go for?
3 to 6.
3 maximum. There is no point of going more than 3. Okay. إيش السايد effects حقته؟
Blurred vision.
Blurred vision is serious side effect.
Serious.
Hypoestrogenic syndrome.
Hot flushes.
Hot flashes, night sweats, mood swings. Okay. Serious قلنا اللي هو diplopia, and you have to stop it and tell the patient to come see you because there might be a brain tumor that's growing because of it. Okay. دحين clomiphene citrate قلنا في 2 components. أحد فاكرهم؟
Agonist effect و antagonist effect.
لا الكلوميفين نفسه
N and Z. NZ.
في inclomiphene وزو clomiphene. Okay.
ايه. الأكتف انكلوميفين.
الانكلوميفين اللي هو المور بوتنت.
وفي yes والزوكلوميفين. الزوكلوميفين موجود بس just to make it stable, okay? And it goes to get deposited in fat tissue. The way that clomiphene works, just to make it simple for everybody, just as a quick revision, okay?
Anti-ester.
If you remember the hypothalamic pituitary ovarian axis, sorry, let me just put this here. Okay, هذه البيتيوتري gland صح؟ بتطلع للأوفري، بتطلع لها اللي هو من الانتيريور pituitary بتطلع لها ال FSH صح؟ FSH هذا اللي بيحصل كل شهر. الأوفري تقوم تطلع فوليكل ومن أي سيل يطلع الاسترادايول؟
جرانيلوزا.
سيل ويطلع يسوي نيجاتيف فيدباك يقول للبرين thank you very much I do not need any more FSH. Okay? When you give clomiphene citrate for 5 days, the protocol that I explained before, it goes and binds to the estrogen receptor اللي في brain. So FSH, you give clomiphene, FSH gets produced, an ovary produces estradiol. Estradiol goes to give negative feedback. It cannot because the receptors are occupied by clomiphene citrate here. Okay? So the brain doesn't get the proper message. Why did this ovary did not respond? So it sends a stronger signal of FSH. So you get multifollicular growth. So you increase the pregnancy rate. After 5 days, estradiol lets go and the loop works again. Okay. The only problem in 20% of patients, as we said, estrogen goes and binds to the uterus. This is a transverse view of the uterus, and it binds here, and it does not allow estradiol to thicken the endometrium. So you get either failed cycle or higher miscarriage rate with the use of clomiphene citrate. The other medication that we use is letrozole. I need another volunteer now. What class of medication is it?
Aromatase inhibitor.
Danashamlan. So it is an aromatase inhibitor. Where does it work?
It works at the level of the ovary. It inhibits the synthesis.
It inhibits what? Sorry.
Estrogen synthesis at the level of the ovary.
Right. So what am I drawing now?
Two cells.
Two-cell, two gonadotropin theory. Okay. So this happens in each follicle. What molecule is going into the theca cell here?
Cholesterol.
Huh?
Cholesterol.
Cholesterol. Okay. Under the effect of which hormone? What hormone binds to the theca cell? When في LH or FSH receptor. Okay. Mainly it's LH receptor on the theca cell. Okay.
Yes.
The cholesterol goes to converts to what in the theca cell?
Androstenedione.
Androstenedione. Androstenedione gets pulled into the granulosa cell under the effect of FSH you're giving her and gets converted to what?
To estrogen.
Estradiol. And then estradiol gets released into the serum, or it goes back to give negative feedback to the pituitary gland. Aromatase inhibitor works here. It blocks this conversion. Okay? It does not have negative feedback on the uterus. For the uterus here, the pituitary gland does not get the estradiol it needs only for 5 days. So it still produces higher FSH, and then you get the negative feedback. The beautiful thing about letrozole is that it does not cause thinning of the endometrium. It is, for the exam purposes, it is the first line treatment for ovulation induction for polycystic ovarian syndrome patients. This is by all the new guidelines, okay? I never use clomiphene for all my patients. I like to use Femara for all of them, okay? Now, just to end the lecture quickly, what is the success rate of clomiphene citrate or Femara pregnancy rate?
10%.
10%.
8 to 12.
8 to 12%. What's the twinning rate?
10%.
8 to 15.
10%. For IVF, it's a little bit higher. It can reach up to 30%. Any questions? So, for question here, even if it is not FDA approved. So the reason why Femara is not FDA approved for the use of ovulation induction, the only FDA approved oral ovulation induction agent is clomiphene citrate. The only reason why Femara is not approved, what is the main use for Femara?
Breast
cancer.
breast cancer.
So I actually contacted the company because I wanted to know why are they not trying to get FDA approval. They do not want to go into, they sell enough of it that they don't want to promote it for fertility. They want to just keep using it for breast cancer. But you can absolutely go ahead and use it for patients with for ovulation. I have a question here. If patient resisted to clomiphene for the first cycle, if we want to start second cycle, will we induce cycle again by progesterone? So if a patient is amenorrheic, meaning she does not get periods, okay, and she's polycystic, you have two approaches in that patient. You do an ultrasound, okay? You measure the endometrial thickness. They randomize patients in studies. Should we induce a withdrawal bleed and then start ovulation induction? Or should we just go ahead and start? When you go randomly start, the pregnancy rate was higher without giving a withdrawal bleed. So the answer to that question for the person who asked, you do not need to give withdrawal bleed to patients before you give ovulation induction, provided that there is no dominant follicle there. Any other questions? Any comments?
How about the endometrial
This is an
thickness?
excellent question. So tamoxifen, in reality, it is the same as letrozole. It is an aromatase inhibitor. So why can't we use tamoxifen for ovulation induction? I need a good answer for people who attended with me.
الإفكت on the cancer uterus endometrium.
مو بيسوي كانسر، بيسوي thickening للendometrium. People that use tamoxifen يصير لهم honeycomb appearance of the lining of the uterus. One of the side effects in these patients, when they use tamoxifen for a prolonged period of time, they get unwanted thickening of the endometrium ويصير لهم polypoid appearance. That's why women who have breast cancer and are tamoxifen, they send them to us as gynecologists to measure the thickness of the endometrium. And sometimes we go and do endometrial resection for them, and some women we do a hysterectomy for them, unfortunately. Another question I have, does clomiphene cause borderline ovarian tumors? No, it does not. The use of ovulation induction agents have been studied thoroughly. It does not cause any malignancy, whether it is ovarian, uterine, or breast cancer. The thing is, infertile patients per se are at higher risk for these cancers. However, once they get pregnant, their risk goes back to the baseline like the general population. Another question I have, can you repeat the point about amenorrhea and induction? If you have a patient who has long-standing amenorrhea and she comes to you requesting ovulation induction, you do not need to give her withdrawal bleed to start ovulation induction. You can do random start. You tell her to go ahead and start it today. How to deal in hyperprolactinemia patient in ovulation induction. This is another lecture I will arrange, inshallah, with Dr. Haytham Badr to talk to you about how do we deal with hyperprolactinemia for patients, because it's different. First of all, it's different for patients going for oral ovulation induction and for patients undergoing IVF. When should you get concerned? When should you not get concerned? I think I gave you guys a lecture during my series about hyperprolactinemia. I think I did, right?
Yes.
Yeah, we can repeat it, no problem. I can repeat it for patients. The other medication, there is one medication here that we can use. I do not allow usually patients to go either with rostagasone, I don't know what that is, but we don't, the two medications that are widely used are either Femara or letrozole or clomiphene citrate. Another question from Saeed, what is the cutoff for ovarian cysts to allow ovarian stimulation, to allow induction or not? So when you do an ultrasound, okay, when you do an ultrasound for patients, okay, let's say she came to you day 2 or 3 of the cycle, okay, and you found that she has a cyst inside her ovary. Sorry, let me just draw this. You saw a cyst, okay. The thing you need to ask yourself, okay, is this a functional cyst? Non-functional cyst. How can you differentiate?
By estrogen, measuring the estrogen level.
By 2 things, by measuring estradiol
Endometrial thickness.
and endometrial thickness. If this is a functional cyst, it is producing estrogen, which will eventually lead to thickening of the endometrium. Those patients, you cannot start stimulation for them. If it is a non-functional cyst, meaning it's not producing estrogen, the estrogen is low, and endometrium thickness is less than 7, it depends on the size of the cyst. If it's less than 4, you can go ahead and start because it will not impede your response. If it is greater than 4, you do cyst aspiration transvaginally that day, and you go ahead and start. Maria, is it okay to begin ovarian induction in the presence of a new hemorrhagic cyst? Again, it's the same protocol that allows for it, because some women, they have endometriomas. If they have endometrioma and it's greater than 4, you have to operate on her, remove it, and then start. If it is less than 4, you can go ahead and start. Okay, guys? So tomorrow, inshallah, I think we have sent a link on the WhatsApp group for ovarian hyperstimulation. Please, I beg you, read it, because tomorrow there is stuff that you have to have background about before we go ahead and continue. Dr. Hana Ali, if you don't mind, please send it again. Send it to me. I'll send it to Dr. Haytham Badr so that he can send it to people that are not registered on those 2 groups. Again, at the end of the talk, I'd like to thank Dr. Haytham Badr for giving me this opportunity to be part of this group. It makes my life much easier, and it is well organized. Okay?
Thank you very much, Dr. Ayman. It was a wonderful lecture. Thank you, everyone. First of all, I would like to tell you that, inshallah, we're going to work on putting this on YouTube, inshallah, tonight. And I would like to please invite you to register from now for tomorrow's lecture so you don't have any difficulties joining. The second thing I would like to say is that please make sure that you tell your friends that they have to create an account on Zoom to be able to join the lectures. If they don't have or log on to Zoom, they're not going to be able to join. And hopefully we're going to see you tomorrow, inshallah. Please register from now. Encourage other people to register from now. And hopefully we'll see you soon. Thank you again, Dr. Ayman. It was a wonderful, wonderful lecture.
Thank you, Dr. Haytham. See you guys tomorrow. Take care and good night. Bye-bye.
Good night.